We're going to be recording this so that everybody will get the recording. As I said, it goes to my YouTube channel first. So, Professor Bogart, Pediatric Nursing, YouTube channel, you'll see it before you even see it in your announcements. Also, know that there are previous terms recordings there. I say things a little differently sometimes. It might be good to listen to the same type of PowerPoint in me, but maybe different words, maybe a different explanation. So they're there for you if you want to go over them. So I'm going to go ahead and start this up. And let me start this out with the premises. We are now almost into your last term of nursing school. You're going to be going into capstone. And in a capstone, you are made to think, not just understanding and memorizing, these concepts. It's now, how do I apply them? So when I'm doing this review, what I'm doing is I'm applying the information. How do I apply it? These are things you've already studied, so let's look at it. So, I've always said nutrition is one of the most important thing any age child or even adult, even elderly. So when we're looking at nutrition, just don't look at, yeah, they need to eat good, but there are conditions that people have that you need to eat differently for. For instance, if you have an irritable bowel syndrome, nutrition can be a big issue, right? Because it could cause a lot of irritation in the bowel, cause a lot of diarrhea, vomiting, and abdominal pain. So nutrition can be an issue with that. Also, if you're a younger child and growing and you're not getting the nutrition you need, developmentally, they're not going to be with the fine motor, gross motor skills that they should be. Now, nutrition and infants and that good old reflux. Now, we put rice cereal inside either the breast milk or the iron fortified formula. And you're saying, well, isn't that not supposed to be done till they're 4 to 6 months, adding food? And yeah, normally, yes. But every single feed, a child with reflux is spitting up formula, food, calories. Give them a little bit of rice cereal and they'll keep the food down, saving calories. So even if they get rid of that little bit of rice cereal, they're actually ahead on calories. And that's why that works. Now, healing osteomyelitis, bone diseases, right? So again, you've got a child who's got osteomyelitis of the bone. They stepped on something and their big toe is full of osteomyelitis. Not only is it, the rest, not only is it the antibiotics, it's again nutrition, healthy foods, which is fruit, vegetables, whole grain breads, low fat products, and then proteins, the beans, the meats, the fish. So that's how we can heal it better. Whenever you talk about nutrition and overweight, underweight, failure to thrive, obesity, how do we do a history on it? How do we assess it? And that's always, always, always going to be some sort of diet history, 24-hour diet log, 3-day diet history. What did you eat for breakfast this morning? What did you eat yesterday? Those are important things. Also, are they active? Or is it the child that comes home and gets on the TV and iPad and doesn't move all day long? Or do they have PE in school? Are they up? Are they moving? Very important things. It really makes a difference in, of course, nutrition and the calories they eat. Another thing is, for instance, you have a child that has celiac disease. Your responsibility is to look at that tray when they get that breakfast tray, lunch tray, dinner tray, and making sure dietary don't mess it up. Now, I don't eat bananas, okay? I have a high intolerance to them. I've been in the hospital and I can't tell you how many mornings for breakfast a banana's on my tray. Now, I knew better. Do kids know better? For instance, celiac, you put those nice little packages of crackers on the tray. Guess what? They're going to open it up and eat it because those are pretty neat things. Again, your responsibility, remove items that could hurt them before they get their tray. Another thing that can affect nutrition is infants when they get that white thing on their tongue. It is, it's a fungus. It's a yeast infection. It's painful. You can't scrape it off. It's not going to go away. It requires medication. All right. Also, telling the parent, the mother, to wash the nipple before they eat it again if they're breastfeeding, or make sure the bottles are cleaned properly in between feedings. Now, diaper rash. Diaper rash can be due to nutrition. Could be all those food changes that we start introducing at 6 months. One of the things that can happen is a diaper rash. One of the things is diaper rash and infants, they don't like each other. When an infant has a bad diaper rash and they urinate or stool and they're asleep, they're going to wake up screaming. This is a child who's not going to be asleep all night long, where maybe they were before. So if they're not sleeping, first thing, let's look at that diaper. Let me look at the buttocks, make sure, is there a rash there? And then let's treat it. As I said, nutrition, infants, we don't start introducing till about 6 months old. Remember, one food at a time, every 4 to 7 days intervals, because we're looking for the diaper rash, the vomiting, or we're looking for an oral body rash, or anything that could be telling me there's an allergic reaction. Okay, infants, growth development. So let's look at some things that we'll be looking at with infants. So one of the assessment things we do every shift with an infant is to measure their head circumference. Why? Well, not all head, spinal columns, meninges, all of that spinal cord stuff, the fluid doesn't go from the brain down the meninges, spinal cord, and back up and flow nicely. And sometimes it gets stuck in the head, and fluid just keeps building and building and building. So, head circumferences are done, especially at the early age, because if we start seeing the head circumference increasing, we know there's a possibility of water on the brain or hydrocephalus. What would tell us that, yeah, I think so? Which assessment? That's good old Fontenelle. That soft spot tells you the world in an infant. It tells you fluid balance, whether it's too much, too little, too much pressure in the brain. Okay. So again, Fontenelle, big thing. Always remember infants, no matter if they're born with something like, let's say they have a tracheal esophageal fistula. And we know if we feed them, that food's going to go right into their lungs so they cannot eat until it's fixed, right? Well, infants still are normal infants. Cognitively, they're normal infants. What do they need for normal growth and development? That good old sucker, that pacifier. It soothes them, it gives them comfort. So don't forget it. Another thing that you hear with office visits, with parents that have more than one child. Well, my other child was sitting up at 6 months old, and this baby is 8 months old and just started to sit up unsupported. And then you will say, well, all babies are different, and your baby is normal. You're supposed to, by 8 months, sit up unsupported. Your other baby was just a little earlier. And this is some encouragement parents need. Another thing with infants, and now this goes into nutrition, failure to thrive. We do daily weights every day on any child in the hospital. We do weights on any child to going to any urgent care, ER, doctor's office. So we're really on top of their weights, really much. So you have a child that's FTT, failure to thrive. That means the milk, for whatever reason, it's not being absorbed, or there's vomiting or diarrhea. Something's going on. One of the things that we can do for these failure to thrive, we also do this like with the heart failure patients, is give them high calorie formula. It just, that little bit they get in, maybe it's going to give them more calories than they need. Okay. So it gives them that extra calorie. So high calorie formula in a child who's too tired, too lethargic, or needs extra calories because they're too tiny, failure to thrive, we can put extra calories in the formula or breast milk. Now, toddlers, what do we know about toddlers? Well, we know they're into everything, and it's all automatically me, mine, autonomy, right? Everything's mine. Now, in toddlers, when we are doing any sort of assessment on them and we're teaching them, if we show them on a doll, they can understand. They can touch the equipment, look at the equipment. Remember, get below them, get on their level, use toys, use games to play with them to teach them. And now you are not threatening. Remember, toddlers want mommy at bedside and want routine. Preschoolers. Preschoolers are getting more and more active. These are more fine motor skills. They're using scissors. By the time they're about 6, they're tying their shoelaces, buttoning their buttons, and their speech. They start at one word at 12 months or 1 year old. And by the time they're 3, it should be 4 or more word sentences. They're starting to be able to express themselves more. Now, at the ages of about 2 is when we start to diagnose children with the possibility of autism. This slide is just to let you know that there are different ways to measure them. We know the behaviors. They're those repetitive behaviors. They don't like eyesight. They don't like touch. They don't like noise. They don't like light. They like playing alone. They don't respond. All of those things, right? But there are questionnaires that we can check off that will show it. And that's what I wanted you to know with this. Now, school age children. You've got a school age child who now was in the normal growth rates. Remember, this is what we do every visit, height and weight, checking what these children are. And now we're starting to see a child being on the shorter side. And it might be a possibility for growth hormones, right? Well, how would you know if it's appropriate? Well, if the family is all of regular or tall heights and the child is small, if you gave growth hormones, it would work because the hereditary, it's the possibility. If the rest of the family are all short, it's not going to make any difference how much growth hormones. And that would be the question you would ask. So tell me about how tall is your dad? How tall is your grandma, your grandpa? Understanding how tall is the family. School age children do worry about their brothers and sisters, their siblings. Again, today we're lucky. We used to send cards home. I used to send home bows and ribbons for the girls. Today we've got, FaceTime. We can talk to them. It's not like before. But again, keeping them involved is important. Admitting children to the hospital for surgery school age. This is the big time it happens. Isn't this a lot of those TNAs, right? Tonsils, adenoids that they get in the tubes in the ears. This is all that time that they do these things. Again, remember, if a child has had multiple surgeries, or let's say they're a sickle cell child, they're in and out of the hospital all the time. One of the things we forget, we think that they're accustomed to the hospital and they're going to react okay. Remember, they might have had a bad experience. So understanding reactions to previous hospitalizations can help you deal with this one. It could have been x-ray guy he didn't like, or the CAT scan guy, or maybe they didn't like the lab tech guy, or whoever it is, we can talk to that child about it, especially school age. Now, adolescents. The one thing about adolescents is when they have a chronic disease, making sure that they are with other adolescents have similar diseases to talk about it. Adolescents think that they're the only ones, and they think that their moms and dads are the only ones that make them and don't let them do this and that. Putting them with other children, talking about it, whether it's about congenital heart disease or cystic fibrosis. Again, getting them with other children their age, it's like doing a teaching, because now you're, back and forth between the kids. They'll listen to each other better. In adolescence, we know they're going to be starting and ending the puberty at this point. Knowing Tanner stages. I've seen Tanner stages on the Hesi. And the way that I want you to remember this is number 1 is absolutely nothing. You are a child. And number 5, you're the mature female or male. So we only have 2, 3, and 4. which could be the stage. Knowing the first stage is either breast bud enlargement or enlargement of the scrotum, which stage would it be? If they were asking about the areola, that would be stage number 3. And you would know it wouldn't be stage 1, 2, or 5 if you knew the start, the end, and what the beginning symptom was, okay? And that's Tanner stage. It's how I remember it also. Another thing with adolescence is about sex and asking about oral contraceptives. You know, many adolescents, I know my mother, I had 6 brothers. There was no way I was talking to my mom. And many, women are like that. They can't talk to their parents. So what can we do? Well, nurses, whether you're a school nurse or you work in a clinic or whatever you are, you can give an adolescent information, oral and written, on the benefits and risks of it, not your opinion, okay? But yes, you can. So let's go into a little bit of the theorists. So let me tell you the way you can remember things. Piaget is all about thinking. I didn't know how to grasp my hand. And then all of a sudden that reflex went to voluntary. Oh, I got my rattle. Oh, and I shaked it, made noise. Oh, I'm going to make more noise. Oh, fell in my mouth. Oh, I like it in my mouth. Again, learning. One of the things they learn is all about, I saw my binky, my bottle, my toy, whatever, somewhere. Where did it go? I know it's here somewhere. That's called object permanence. Once they see it, they know it's there, even if it's not in visible sight. Eric's all about
Yeah.
how does a child deal with their environment, their people. So how do an infant talk about the people? So an infant, what does an infant know how to do? They can cry. When they cry, what do they want? They want somebody. So they're calling somebody. So that's when I trust. And that's Erickson. I trust somebody's going to come feed me. Somebody's going to come pick me up and change my diaper. We know that not trust or not trusting is when somebody doesn't go in. And that's usually due to some sort of abuse, or maybe it's alcohol or drug abuse or homelessness or something. But infants want to be trusting. They want that person to come. School age children, Erickson says that school age children does certain things very well, and that's their industry. That's their factory. That's their product they produce. My industry is I'm good at math. My industry, somebody else might say, is I run faster than anybody. My industry, what do I do good? That makes me feel good. That makes me feel achievement. And we know the inferiority, the other side is I can't do everything well, and I wish I could. Remember with adolescents and Erickson, they're all talking about identity, body image, who am I, role, confusion, all of that, right? So if we're talking to an adolescent regarding body image and all that sort of stuff, you can have parents leave the room. It's absolutely okay. And you don't have to tell the parents what they told you, unless it's something that can hurt them or others. So let's get into some body systems. Hematology, blood. What do we need to know about blood things? Well, hemophilia, what is it? It's when you bleed because you're missing some sort of factor in your blood. So without that, you're going to continue to bleed, bleed, bleed. So let's look at things like safety, infection control. This will always be part of any type of exam. So safety. Remember, toddlers, they're in running around all over. Make sure we protect the environment for them, as in patting furniture. You can't stop them from running, can you? A toddler's going to do what they want, but you can protect where they are playing at. Remember, if a hemophiliac does fall and they have severe knee trauma or elbow trauma or shoulder or whatever, it's bleeding in a joint, know that what do? We immediately rest, ice, Contain it, elevate. That means ACE bandage, ice it, elevate it. We are trying to decrease the amount of bleeding, and they can give the factor at home, not a problem. How do we take care of nosebleed, epistaxis? Thumb, forefinger on the bridge of the nose, lean forward so you don't swallow blood. It can come out the mouth and you won't vomit it up for 10 minutes. If it's still bleeding, you need to get to medical attention. Many times during this course, we talk about platelets being low, whether it's due to idiopathic thrombocytopenia purpura, that ITP diagnosis, or it could be due to overwhelming sepsis. It could be due to so many different things. In leukemia, it could be. Any of these diagnoses could have a low platelet count. What will always be our concern, no matter what the cause? Bleeding. Bleeding precautions, always bleeding precautions. Sickle cell disease is all about vessels too small and little blood cells getting stuck. And it clumps up and it swells and blood can't get down the blood vessels. So how do we prevent this from happening? Well, we need to keep those blood vessels plump and big. So keep hydrated. Keep warm dressed in cold weather. If you're going in an airplane, drink extra fluid. You want to keep the blood vessels open and big as possible. ALL, leukemia. Remember, you are immunosuppressed. Remember, with ALL, your white blood cells are low. You're prone for infections. Your hemoglobin, hematocrit are low. You're tired. Also, your platelets are low. You're apt to bleed. All three things with ALL. And then how about sickle iron deficient anemia? One of the things we do for children is diet and also medications. Remember, iron is through a straw, empty stomach, because you need stomach acid to digest, and orange juice helps digest it better. Orthopedics. One of the things that we have to remember with orthopedics and let's just say even school-age children, when we're giving instructions to children, school-age children need to have their own written instructions. They are a great group to teach and they can take care of themselves really, really well. You know, they need to know their written instructions, and then we need to look at, are they adhering to what we're supposed to do? Are they compliant? Are they taking their meds? Are they checking their blood sugars? Are they not checking the neurovascular signs of that cast that was just put on, et cetera, et cetera. Orthopedics, you fell off a monkey bar. What do you do first? Well, what are you worried about with a broken bone? Well, let's get that immobilized and check neurovascular signs always. Any sort of orthopedic injury, always think neurovascular signs. Is blood still getting there? And then get them to help, all right? Physical therapy for JIA. So I have rheumatoid arthritis, okay, juvenile idiopathic arthritis, whatever, it's the same. My joints are being attacked. And one of the things that you need to do, or you'll get stiff and not move, is to do some sort of exercise. The best thing is a swimming pool because you're floating and you're still moving your joints and it's not painful at all. So status post Harrington rods. What is this used for? Well, just think about that child who just had a scoliosis repair, has had a Harrington rod placed in there. It's the whole back of the spine. It's this whole rod. Oh, it could be 8-10 inches long. And it connects to the nerves, the outpatchings of the spinal column. And those are the pictures, what it looks like. Post-operatively, it's very fragile. This is your log roll. We've heard about that in foundations, right? This is your patient that is going to be log rolled. Again, osteomyelitis, again, recent infections. We know this is all about diet. We need to make sure they get the diet they need. Now, cardiac disease. Kawasaki disease. What is it? It is systemic vascularitis. Those vessels are inflamed and fragile. little embolus could be floating around, and we're worried about coronary arteries getting big and having an aneurysm. Treatment. IVIG, let's boost that immune system. Let's make my body be able to fight this viral infection. And also aspirin. Why do we give aspirin? It thins the blood. It's like giving Coumadin. It makes the blood go through with all of these little vascular itis, maybe microembolus there. Prostaglandins is used to keep that oxygen giver or that patent ductus arteriosus, fetal circulation, open. One of the side effects is bradycardia, and actual hyperthermia is the other one. If it's on a little bit too fast, then all you would do is slow it down, and it would be fine. Indomethacin is the opposite of prostaglandins, right? Prostaglandins, we give the oxygen for whatever reason, whether it is a transposition of great arteries, usually. And indomethacin is that patent ductus arteriosus is still open. I don't need it. I mean, it's already 3 weeks after the baby's born, and I still hear the murmur. I still see a wide pulse pressure. It's still open. What I can do is medically give a drug called indomethacin or Indocin, and it closes that PDA. And how do you know it worked? That murmur has gone away. It's decreased, and that pulse pressure is going to come back to normal. It's not going to be 60/18. It's going to go 60/40. That's what it should be. So congenital heart disease, and you're having a deteriorating condition, it means they're starting to struggle a little bit more. And all of a sudden you see a weight gain. What would you see? Well, with a congenital heart disease and you see a weight gain, you always think of heart failure, right? Weight gain is one of the things we do every day to monitor that. You would see tachycardia, your blood pressure would go down. And what would happen to your lungs if you're gaining weight? Where's the fluid going? Where's the weight going? Fluid in the lungs. So you would hear your lungs getting all full of bronchi and rales. Cardiac cath, nursing care, greatest risk, always bleeding. There are two big, huge catheters in the right femoral artery and vein. So again, checking for bleeding is your big thing. Remember with digoxin, it's just like adults, apical heart rate for a minute has to be above. Now, an infant would be maybe above 100, maybe above 120. With an adult, it's above 60. So knowing your different ages for that. But they usually talk about infants when they're giving dig administration. Looking at their potassium. So is their potassium normal? Or you can go to dig toxicity. If they've had a dig level, what was it? And again, knowing vital signs. Rheumatic fever, we mentioned it in cardiac because that's due to a strep infection, and it can hurt your mitral valve. And once it's hurt, it's going to have to be medically or surgically repaired. Urinary system, urinary tract infection. One of the things that we can figure out is when a child who has not been bedwetting all of a sudden starts to wet their bed, we need to figure out why. It could be as simple as a urinary tract infection. It could be diabetes mellitus, diabetes insipidus. It could be other stuff, but the first thing we always will check is the simple urinary tract infection. Cryptorchidism is when the testicles don't come all the way down in the testicle sac. You must, when you are doing this evaluation, have this child in a warm room. Testicles, when they're cold, suck in, so the balls will go in further. If it's warm, they'll hang normally, and that's what we want. We want a normal-looking testicle when we look. One of the things we don't think about is children getting a bad infection, staph infection, be placed on things like the aminoglycosides like vancomycin for long, long periods of time to cure whatever it was, right? Remember the side effects of long-term antibiotics. I mean, we have the nausea, vomiting, diarrhea. Those are the first things we see, but longer term is like things with a CIN, aminoglucosides, can affect and destroy your hearing. Okay, ototoxicity, and it also nephrotoxicity. It can kill your kidneys too. So monitoring hearing, urinary output, even after they go home, extremely important. And nephrotic syndrome, as I said, this is not kidney failure. The kidneys are working. The problem is it doesn't like protein and it spits it out. And because the protein comes out of the blood system and everything, what happens is that osmotic, isotonic, hypotonic pressure thing, fluid is pushed interstitially. So they're full of fluid all over the place. So one of the ways that we can treat nephrotic syndrome at its worst when they're very swollen, protein levels are low in the blood, we can give albumin, 5%, 25% albumin, which is protein. Albumin, protein, same thing. And what it does, it pulls the fluid out of interstitially. And what are you going to see? Increased in urinary output. So give some albumin. I would give some diuretic afterwards and flush it out. And all of a sudden, you'll see a lot of urine come out and the edema is going to decrease. These are some conditions with their urinary hypospadias. Hypospadias is a condition. There's epispadias and hypospadias. Hypospadias is when the urethra doesn't come out the tip of the penis, it comes out somewhere on the bottom. And the thing about this is this child cannot be circumcised, even in the Jewish faith, which might be a big deal, okay? They need that foreskin in order to do a plastic closure, and they will do it before they're potty trained. If you look at the picture below, they fillet the penis completely open, create a cavern, and they put a catheter in there to keep the lumen patent. That catheter stays there for 7 to 10 days. We do nothing with it. We don't touch it. Just make sure the end of the catheter is inside the diaper or urine will be everywhere. That's all we do with it. And again, you have to save the foreskin, and it's done before they're potty trained. Wilms tumor. This is the tumor on the kidney. This is the big thing. Do not palpate abdomen, right? The other thing that you don't think about with Wilms tumor is if I can't touch this, why do I just do surgery? I do chemo or radiation and do surgery. I don't do a biopsy. The reason why you don't do a biopsy is because you're puncturing a hole in it, and now it's like manipulating it and do not touch abdomen, right? You've released the cancer inside the peritoneal cavity, okay? So chronic kidney disease, osteodystrophy. Well, take words and break them apart. Osteo, bone, dystrophy is a disfigure. It's just not right. So one of the things with it, it has to do with calcium and vitamin D and erythropoietin. Know that with osteodystrophy, if we can make sure they have erythropoietin, calcium, vitamin D, we're going to have a better child with less bones that won't be as disfigured. Again, glomerulonephritis, rheumatic fever, both are due to strep. And with urinary and boys, testicular pain is a true and real emergency. It must be seen right away, or sometimes they can lose the testicle. It tends to torsion, it twists, cuts off blood supply, and we're trying to save future babies. Respiratory, epiglottitis. Well, let's start with croup. Croup is upper oropharyngeal airway, and you can't get air in. If we treat croup, and if we don't treat croup, and it gets more and more swollen, it turns into epiglottitis. Epiglottitis is the epiglottis covering the trachea. So I'm trying to get air in, and I've got this cover on my trachea, and there's no way to get air in there. What do I need at the bedside? Remember, airway, airway. I need a tracheostomy tray or an intubation tray, both at the bedside. Remember, epiglottitis is that drooling, it's that frog-like voice, it's that inspiratory. You can really tell, and they're just look absolutely restless, hypoxic. Remember asthma, especially with children, that if they're getting it, making sure they use a spacer for the meter dose inhalers, using those masks, really make sure they get their medicine. The other thing about croup. So many children come in with croup. We treat them with a dose of whether it is an inhaled racemic epi or racemic epi and a steroid. If they go home and now all of a sudden they're not swallowing, what's happening? That's epiglottitis. Okay, so if a croup child is not swallowing and drooling, get them back to the ER right away. They're in acute respiratory distress. RSV, respiratory syncytial virus. Remember, this is in the infants. That's like usually 1 and under are the ones that are really hurt by it. And it's just because there's mucus in their nose. They can't suck, swallow, and breathe. So we suction their nose to feed them. One of the things with RSV is it's okay for normal infants to get it, but if you already have cystic fibrosis or you have you were premature or cardiac disease, you are going to not want to get this disease. It's an over taxing on the body. So we can do a monthly vaccine called Synagist. Another thing, as we're placing these children in the hospital, some of them, because they're in acute respiratory distress, will be admitted. Some won't, but many will. Make sure that we look at immunization status in any children, because a cough could be a pertussis or it could be just an RSV or common cold. But if they're not immunized, we can't take the chance with other children. Know the signs and symptoms of respiratory distress in infants. We have all the signs that we see in adults, but remember, in infants, it's that nasal flaring and that grunting at the end of every breath. Cystic fibrosis. Why do we do chest physiotherapy? Well, we give an albuterol aerosol, then we give chest CPT, and then we give them their enzymes, and then they can eat their meal or their snack. Big thing about the cystic fibrosis is the cleaning equipment, because all of the infection that could be in that mask. And cystic fibrosis, many times, if we don't know at birth, this will be the one that has a meconium ileus, no stool, the first day and a half. Also, if we licked their skin, it would taste very salty. And I'm not telling you to lick anybody's skin, but if the mother did, it would be salty. And we do that test with a sweat chloride test. And we know albuterol is a rescue when you can't breathe. So with GI, again, if they have diarrhea, the one thing, okay, they have diarrhea, making sure you check their buttocks, see if they have breakdown. Usually nurses and facilities have some better creams that we can offer them. Another thing, abdominal pain. Well, where is it? Is it right lower quadrant or is it umbilicus? It will determine what's your level of severity of care. Right lower quadrant, it's an appendix. Umbilicus could just be a little bit of GI pain, which you have more time to treat. Know that children, status post-abdominal surgery, for instance, when you're going in to take out that Wilms tumor, you have to go through the whole abdomen, through all of the intestines to get to the back where the kidneys is. Remember, these sort of surgeries, with all of that manipulation, can cause a paralytic ileus. And what is a paralytic ileus? well, the intestines stop working. So then you have these severe colicky pain, you're nauseous, vomiting, and your belly blows up. That's what happens when sometimes these really going into the abdomen and manipulating it. Pyloric stenosis. This is when the pyloric valve is thickened and muscular, and you can't get milk going into the small intestines. So what do? Well, this one is across the room vomiting. Know that this one, you're going to feel that little pyloric valve, whether you're going to feel an olive size or you're going to see, I call it a marble, but it's hardened. You can actually feel it right underneath the xiphoid process. And again, it is that projectile vomiting. Intussusception. This is when the intestines suck into each other. And know that with intussusception, this child, we need to get that intestines out. And the way that we do it is to keep fluid volume. So it keeps it plump so it can move. If it gets dried out, it'll suck in on each other. So treatment, in case we have to do surgery, because that's the ultimate treatment, NPO, give them IV fluids. And especially if they're to the point of so exhausted that they're getting lethargic. Now, reflux, gastroesophageal reflux disease, children, older children, figuring out bland foods. And sometimes the choices are, what foods do I choose? Well, if you had to choose things like pizza, chocolate, ice cream, well, looking at all of those, that is a lot of fat, caffeine, spice. So maybe a cookie is the best choice, a piece of bread, a toast. You got to look at choices and figure out which one's the least of the evils when you're figuring out food choices. One of these symptoms in the GI that we go over just a little bit is biliary atresia. This means there's no connection between the liver and the small intestines through the duodenum, right? So what happens is that bile in the liver spews into the blood system. So you're going to get jaundiced skin. Sclera is going to be jaundiced. The urine's going to darken up. And the other thing that happens is there's no bile in the stool. So the color of the stools get very pale. Neuro, ringing in the ears. You get a child coming, you're the school nurse, complaining, my ears are ringing, ringing, ringing. What do you do first? Well, look inside. I've seen cockroaches, I've seen a bumblebee, I've seen crayons, I've seen all sorts of things inside of ears. First thing, look, what's there? If you have all the symptoms of meningitis, headache, photophobia, nuchal rigidity, what can you be sure you're going to be doing next? And that is a lumbar puncture. And why? You have to determine, is it viral or is it bacterial? Remember, with seizures, it's all about safety. We just study that. Turn them on their side, suction at bedside, clear any toys out of the way. You know, that is all about seizures, nothing in their mouth. Protection of airway. Febrile seizures, probably one of the trickiest. That you've got this young child who had a fever and then got a fever right after. They've gone from no fever to a fever within 20, 30 minutes. And that rate of rise is what the brain sparks and says, oh, I don't know what happened here. And they have a seizure. Now, parents all the time will say, oh my goodness, does that mean my baby has epilepsy? And the answer is, unless they're having 2 or more unprovoked seizures, it is not epilepsy. Myelomeningocele, gastroschisis, bladder exstrophy, anything with something born on the outside, there's things we need to do. Well, first thing we need to do is put a sterile dressing with normal saline on it, right? We got to keep it clean, infection free. with a myelomeningocele, because there's going to be multiple surgeries. We make these children always latex allergy, which means no latex around them, because they might be getting frequent urinary catheterizations. They may not feel that they have to urinate. Also, we need to monitor their stools. Are they moving their stools? Can they feel that they have a bowel there? And more neuro. Duchenne muscular dystrophy. Duchenne muscular dystrophy is usually diagnosed right around 2 years old. Boys, somewhere in that age, up to about age 7, these are children that cognitively delayed, but they're up, they're walking, and then all of a sudden, by the time they get about 2, they start falling. Their muscles start getting weaker and weaker and weaker. And they've got to figure out, what is this muscle weakness from, and measure that weakness. So Duchenne muscular dystrophy, a test they do to diagnosis, is called an EMG, electromyography. And what it does, either put a tab or a tiny little needle, usually just a skin tab thing, and they put an electrical shock into a nerve, and they see how quick the muscle responds and how much response is there. Now, once they do this test, and they test all the muscles of the body, this child feels like he's ran a marathon. So, number 1, warn the parents and the child. And number 2, have some Tylenol, acetaminophen, or ibuprofen for the child, because they're going to be hurting when they come back, and especially the next day. Eye patches, eye injuries. So with eye injuries, you have something that's in there, we don't remove it, put a Fox shield on it, we patch both eyes so there's no movement, and get them to some sort of eye help, whether an ER or a pediatric ophthalmologist. Nystagmus. Remember, it's an eye exam, that 6 cardinal positions of gaze with it. Know that that's the ones that they move. Hydrocephalus, again, it's water on the brain. We've discussed it. Remember, we'll see increased head circumference, and what they'll do is they'll put in a VP shunt. Now, as a child gets older, that shunt needs to grow also, and it's gotten to the end of that growth and it disconnects. These children come into the ER, severe headaches and vomiting, and we do an x-ray, we call them a shunt series, we find the shunt's not working, and we send them to surgery and we reconnect it. The next day, you as a nurse walk in and you're assessing this child. How do you know that VP shunt revision worked? Their headache is gone, they're not vomiting. As simple as that. Endocrine. Many times endocrine is all about growth, right? Growth. So detecting hyperpituitarism, height and weight, which we do all the time. Parathyroid, what is it? It measures calcium. So low or hypoparathyroidism, your calcium's low, your muscles are weak. Hyperparathyroidism, your muscles are in spasm because it's too high. With DKA, the plan of care is, when that child comes in, IV fluids and an insulin drip to get that blood sugar back down. With DKA, with diabetes, with children with these chronic conditions, that they need to be treated normal. If they check their blood sugars, take a snack before they are out there playing whatever they like to do, and having snacks available, keeping them normal as possible is what we have to do for them. With diabetes, we have to teach, rotate the sites. Can you imagine? These children are age 2. They're a type 1 diabetic. They're going to be getting sub-Q injections for life. Make sure they rotate it so that we have plenty of places to go as they get older. Teach the symptoms of hypoglycemia, sweating, shaking, headache, nausea. How do we treat it? glass of milk, glass of orange juice, sugar cubes, something. Thyroid hormones. Now, there was a question that I've heard students tell me about the thyroid hormones. If the TSH is high, the T4 is low. And if the T4 is high, the TSH is low. So they're opposite of each other. It just has to do thyroid hormones. That's the way they work. When you have an adolescent, let's say their BMI is 95%, which means they're quite heavy, right? What would you suspect could be the causative reason? Well, BMI is high. We're going to be doing a urine test. We're going to be doing hemoglobin A1C. And we're, of course, if we are looking at any other symptoms they might have. Remember, BMI doesn't mean they're just heavy. It could be due to some sort of symptom there too. Common childhood diseases. We don't really go a lot over these, so I'm putting them here. Impetigo, very bad staph infection, extremely contagious. These lesions don't pop them. It's oral and topical, and it spreads. Wash your hands, wear gloves. Conjunctivitis. Remember, that's another infection, clean inside out. Also, if you're putting ointment in an eye, for a child or adult, tell them it's going to be blurry because that would scare me. All of a sudden, I can't see, right? And again, cleaning inside out and then putting the ointment in. Child, if they've had a tick around and you see them with a fever, know that checking their whole body for more fevers. And then, of course, getting to the doctor. They may need to do some blood tests 10 days after exposure. Tetanus shot. Tetanus, remember, if you step on something and there's an open area, most children today are immunizations up to date. Number one, check the immunization status. Are they up to date? And the wound, we forget this, clean it with soap and water and put an antibiotic ointment on it. And of course, whatever tetanus we need to do. Chicken pox. Chickenpox is communicable 2 days prior to the onset of the rash, so before we even know, and then until all of the lesions are dry and crusted over. That's chickenpox. Head lice. Remember to check the head follicles, and we put the shampoo, fine-tooth comb. We put things in plastic bags for 2 weeks to make sure that we kill all of the lice. Otitis media, one of the big things that causes otitis media is smoke. So secondhand smoke we should avoid. Also, if a mother is breastfeeding, it decreases the incidence of otitis media. With children, activity deficit hyperactivity, these children can't finish things. They go from one thing to another to another. So one of the choices is just the organization. The organizational charts, being consistent, one place to do homework so they don't think they can do anything else there. Also, they might do the stimulant meds. That tends to calm them down and gives them focus. We've already talked about your nosebleeds. So infectious disease. Infectious disease, low neutrophil count. Does it matter any diagnosis, whether it's a leukemia, whether it's just somebody's status post appendectomy, or any patient? Any low neutrophil count in a child or an adult that also has a fever is scary. There is no immune system. This is a patient that's going to go into septic shock now. So if you have a group of patients and one, I don't care what the diagnosis is, low neutrophil count and is now running a low-grade fever, that's the first patient you need to see. That's a priority patient. Remember, with infection control, washing hands is number one. Using proper equipment. I think teaching parents not to walk out of rooms that they're not supposed to, like the ones with respiratory or airborne air droplet isolation. Immunosuppressed children, if you have a child, just like low neutrophil count, you see a fever, that's always going to be your priority. Immunosuppressed is just like low neutrophil count. You need to treat them as your priority, and get them treatment, get antibiotics or what they need now. Giving immunizations to infants, they hurt, parents complain about it. We can use cool packs on that area. And for the first day or so, depending on their age, we can give Tylenol or acetaminophen or anytime they want to. Motrin when they turn, or ibuprofen at 6 months. You can't give it before 6 months. And then you pedal the legs, and that tends to move the medicine around, and that does help. Measles, mumps, rubella, there's always a question, when is that? That's at 12 months. The second at 4 to 6. Rheumatic fever, acute glomerulonephritis, again, it is strep throat. The one thing about rheumatic fever, many parents are concerned about those sudden aimless movements, that chorea, and tell them, yes, it will go away with treatment. The only thing that won't is the mitral valve damage. So you will have acid-based questions on your exam. I'm going to tell you 2 of them and how to figure it out, and you'll be all right from there. So when you have metabolic alkalosis, you're losing acid. When you're vomiting, what do? You vomit acid. You vomit stomach acid. What are you left with? You are left with metabolic alkalosis. When you're having diarrhea, you are getting rid of enzymes, alkaline enzymes. What is left? Acid, metabolic acidosis. And then the last thing I want to tell you is when you hyperventilate, you're blowing off, it's respiratory alkalosis. Remember those and you'll be good. The one thing I'll tell you guys is when you read the question, get your answer. When you think you have it, go back and read the question again and make sure you're answering what it's asking for. Most common mistake that students make. Guys, I wish you luck. Again, you're going to see this posted first on my YouTube channel. Thank you for coming. I wish you the best.
Thank you.
My pleasure.
Thank you.